Hey.
Hey, Madison.
Hey. How's it
How's
going?
it going? Good. I'm excited.
Yeah, me too. So you're introducing 3 people or 2 as well?
I'm going to do 3. I'm going to do Ashley Madison, Dr. Elna Hall. Well, actually 4 with the moderator, Professor Ho, and then Professor Frankford.
Do you want to do like all of yours at once and then mine, or do you want to like alternate?
I think we should do Professor Frankford last.
Okay.
Yeah, I think that's a good idea.
I think you should do one second. Just gonna look at who we have. You think you should do Professor Frankfurt first or last?
Yeah, I think we could do him last and like make it so that we introduce him and then he just runs with it from there.
Okay. Hi. Okay, so then I think you should start with one of your people, and then I can do maybe Professor Marlank or Dr.
Okay,
Marlank.
I'll start with I'll start with Ashley, then you could do Dr. Marlink. I'll do Dr. Elma Hall. You could do Professor English. I'll do Professor Ho and then Professor Frankfurt, and then we'll transition to you, Professor Frankfurt, to start after that for introductions.
We can't hear you. You're muted.
Oh, you're still on mute. Yeah.
Oh, I need to make you a co-host. Can you unmute yourself now?
Yes. Hi.
Hi.
Just a brief introduction, basically, unless you've been asleep for the past number of months, how important this is. And, I'll just talk like 30 seconds about disparities and jump right in.
Sounds perfect.
Sounds good? Okay. And I'll thank everybody first.
I'll set up the Lexis tip. It's a pretty quick tip, which is nice.
Ryan, package just came, so it was tight.
Oh, perfect.
And Buddy's under orders not to bark, but I can't promise that.
That's all right.
I'll just mute as fast as I can.
I'm excited. I think this is going to be a really good panel.
Me too.
You guys did a great job. I mean, I have to admit, I didn't really focus on, who the people were until this past weekend, and you did a great job.
All of it goes to Ryan.
I mean, you were the one who came to me with the idea, Madison, so definitely wouldn't have happened without you as well.
Do we have any idea whether we're going to get participation from other parts of the university?
I know that Dr. Marlink is advertising in his school. There were a couple people emailing me back and forth asking for the information, and then they sent a little screenshot of where they shared it. I'm not sure how much of a poll they have, if there's going to be a lot of students or not. Hopefully, that would be nice.
Yeah, hopefully. Let me hide everything else. Others. It's okay. There.
Hopefully the panelists log in slightly early so we can get that all set up.
Yeah, we asked for 10, 15 minutes. I mean,
Yeah, most of them acknowledged it, which is good. So
I'm going to ask them. Oh, I'm sorry.
No, I was saying hopefully we could get started around 5.
Yeah, for each of the 3 questions, I'm going to ask them just to volunteer for one of them to start, so they don't all try to jump in and talk over one another. And then,
do you think that for people who aren't panelists, we should ask them to turn off their cameras during the like not question and answer section? What do you think?
Yeah, I think so. I think you and I could turn off our cameras too. When the pitch engine, looks a little different than last semester, but it still has all the same features. They're just in different places that you can see here on the left. We have a new navigation panel. But today I'm going to show you the at least search terms and connector function. So if you want to use this, you would type in ATL, that stands for at least, and then the amount of times you want to have this word show up in the document or case that you're searching. So this is at least 10 times the word health will show up, and at least 10 times the word COVID-19 will show up. So if you ran this search, you would get these results here. And as you can see, in these cases, it's not just a one-off mention of COVID-19 or health. A lot of the times you'll get cases where it just has one mention of it, or it'll have a lot of health, but not a lot of COVID-19. So this really helps you refine your search, and you can control how many times you want that word to be mentioned. So if you want one to come up 50 times, you would just change that 10 to a 50. And that's it for the Lexis tip. I'll go into the participants list afterwards and send an email out, and you'll hopefully get your points as quickly as possible. But without further ado, I will start by introducing our first panelist, Miss Ashley Madison. She graduated from Rutgers Law School in 2019, so she's a fellow alumni. She's currently working in a 2-year graduate fellowship through Equal Justice Works, an organization that pairs law students with public interest organizations. She now works with the Camden Medical Legal Partnership, which offers innovative, holistic, and community-based legal services to Camden residents with complex health needs. As a law student, she was a social justice scholar, part of Rutgers Journal of Law and Religion, and the Association of Public Interest Law Students, the Women's Law Caucus, and was a teaching assistant for Professor Herbert Hinkle. Ashley also received the Health Law Faculty Award for excellence in health law and policy, including service. She has been working remotely during the coronavirus pandemic to ensure her clients have access to the court system. Additionally, she keeps the care teams of her partnership updated on legislation and policies related to the pandemic. So thank you for coming, Ms. Madison.
Thank you for having me.
Dr. Marlink is a medical oncologist who joined Rutgers in 2016 as the founding director of Rutgers Global Health Institute and the inaugural Henry Rutgers Professor of Global Health. In 2018, he established the Botswana-Rutgers Partnership of Health, where he is helping to build comprehensive cancer care and prevention programs, opening its new teaching hospital and building capacity through the healthcare workforce. Recently, his partnership has expanded to include support for Botswana's COVID-19 response. In New Jersey, he is a member of the Newark Reopening and Recovery Strike Force, established by Mayor Ross J. Baraka, where he helped develop the city's initial COVID-19 testing plan. He is also spearheading an initiative to support the safe reopening and operation of small businesses in New Jersey's low-income and minority communities, and to better prepare those communities for future public health threats. He has extensive experience in epidemic response and capacity building, having worked to establish large-scale HIV/AIDS research, training, and clinical care programs in the US and abroad. His work in Africa on HIV and AIDS research and programs is extensive, impressive, and could probably take up the 2-hour panel if I tried to mention all of it.
It means I'm old.
So thank you for joining us. Dr. English is an assistant professor at the Rutgers School of Public Health. He is committed to reducing health inequities through understanding, combating, and preventing racism, heterosexism, and other forms of identity-based violence. He earned his PhD in clinical and community psychology from George Washington University. His pre-doctoral research focused on daily racial discrimination measurement and modeling its longitudinal effects on psychosocial outcomes among Black US American adolescents and adults. He subsequently completed his postdoctoral research at Hunter College at the City University of New York, where his research focused on examining the health effects of intersectional racial and sexual identity discrimination among Black sexual minority men. Presently, Dr. English's research is focused on the biological, psychological, and social effects of daily intersectional discrimination among young Black sexual minority men. Thank you for joining us.
Thanks for having me.
Next we have Dr. Sharif El-Nahal, who is invited but is not currently here yet, so I'll just do a quick introduction in case he shows up. Dr. Sharif El-Nahal served as the 21st Commissioner of the New Jersey Department of Health and is currently the President and CEO of University Hospital in Newark. During his tenure with the New Jersey Department of Health, Dr. El-Nahal addressed the opioid epidemic by reducing barriers to medication-assisted treatment for addiction. Dr. El-Nahal also collaborated with New Jersey's First Lady, Tammy Murphy, on maternal and infant health initiatives. Previously, Dr. El-Nahal was appointed to the White House Fellows Program by President Barack Obama in 2015. In this capacity, he served in the U.S. Department of Veterans Affairs, where he co-founded the Veterans Affairs and Innovation Ecosystem, a network of innovators, implementation professionals across the United States who develop and scale best practices that have improved healthcare quality, women's health, mental health, and substance treatment, and other areas, the results of which have been published in the Journal of the American Medical Association. He served as the Chief Quality and Patient Safety Officer of the Veterans Health Administration, the largest health system in the United States. And then for our final two panelists, they are currently Rutgers professors. We'll begin with Professor Christina Ho. Professor Ho is the Associate Dean for Faculty Research and Development and New Programs, in addition to being a professor of law at Rutgers Newark. She was formerly the country director for the Clinton Foundation's China program. Professor Ho also worked on the White House Domestic Policy Council during the Clinton administration, as well as Senator Hillary Clinton's legislative staff. She joined Rutgers Law from the O'Neill Institute for National and Global Health Law at Georgetown University Law Center, where she founded the China Health Law Initiative. Professor Ho teaches many different courses at Rutgers, including health law and policy. Thank you for joining us today, Professor.
My pleasure.
And last but not least, our moderator, Professor David Frankford. Professor Frankford, prior to joining Rutgers, clerked for the Honorable Irving L. Goldberg of the U.S. Court of Appeals for the Fifth District Court, worked as an associate at Wilmer, Cutler, and Pickering in D.C., served as an associate professor at the University of Miami School of Law, and was in private practice in Philadelphia. His works and writings have focused on a plethora of healthcare topics, ranging from healthcare politics and policy to the role of professionalism in medical education. He has been involved in many grants of the Rutgers Center for State Health Policy and participated in bioethics projects at the Hastings Center and the Center for Bioethics at the University of Pennsylvania. Professor Frankford also held a number of editorial positions for the Journal of Health, Politics, Policy, and Law. Lastly, he is the Health Law Society advisor. He teaches many health law courses in Camden and is considered a health law expert here at Rutgers. Thank you for moderating, Professor Frankford.
Pleasure.
Okay, great. Now we're going to hand it over to you, Professor Frankford. I would just ask that everybody mute and turn off your cameras so we could have our moderators in gallery view without anybody else up, just so it's a cleaner picture. Thank you very much, Professor Frankford.
Okay, so thank you for coming. Thank all of you who are out there in Zoom world for coming. And the silver lining of Zoom world is that we can attend from anywhere. And thanks to the panelists, we have an astonishingly good panel, remarkable credentials, and I look forward to learning a lot from each of you. And thanks to the Health Law Society and OUTLaws, and particularly Ryan and Madison, who did an amazing job in putting this thing together. And I greatly appreciate it. And I'm sure Dean Ho does too. So the topic of our meeting is obviously the disparate impact of COVID-19, the pandemic, on vulnerable populations. And I'll leave it to our panelists to talk about what vulnerable populations can consist of. But obviously this panel is very timely, unless you've been asleep for months, right? You know that the pandemic is causing havoc across the world, and the data regarding the impact on vulnerable populations are downright scary, and I would say, in fact, outrageous. And again, I'll leave it to the panelists to talk about that. Despite political rhetoric, the scientific predictions that things are going to get worse are easily supported by current data. The surges in the United States, the surges in Europe, particularly France, where people thought they'd beat it, and early data from Alaska, which is in winter now and has major community-wide outbreaks, and that cannot be due to outsiders coming in. And so there's also evidence that the virus itself really likes cold, dry conditions. Some viruses don't. This one apparently does. And winter also makes us more susceptible to infection due to the dry air. And last, we're not going to be eating outside and so forth. And so the situation in the United States is dire, and possibly is going to get even worse. And I'm sure that it's easily predictable that the impact on vulnerable populations will continue, if not get worse. Our panelists will discuss the problem is just embedded in all aspects, every nook and cranny of our society. And this is just a problem we've got to address as a nation. Okay, so we've organized the discussion around a number of topics, and I'll invite the panelists to chime in, and my hope is that they actually start a conversation amongst themselves. So we plan that for approximately 45 minutes, give or take, and then 30 minutes, give or take, for Q&A. Okay, so let's begin. First of all, generally, how has COVID affected, whichever is relevant to you, your practice, your research, your clients? And I'd like the panelists to address not only data, aggregate data, but also to bring those data to life by talking about real people. So, who wants to start? Dr. Marlin. I don't have to call them people. You all can just chime in, okay?
Okay, thanks. Well, David, I'd like to start. I appreciate the overview you gave, and the dire situation that the world's up against, and the United States is up against in particular. This is not going away. In fact, it probably won't go away in our lifetimes or in our offspring's lifetimes. We're going to be living with this virus from now on. But and the number of Americans and deaths will continue to amaze us and sadden us. throughout the coming probably 2 years at least. There'll be a number of those of us in public health, view it. There'll be a number of ways that we'll be able to slow this virus down. Some people, I saw a analogy of Swiss cheese slices, with holes in the Swiss cheese, and the virus, trying to come through the air, through the slices of Swiss cheese. And with each either community slice of stopping it or individual slice, community slice might be how we operate outside with masks and distancing. Individual slices might be getting a vaccine, vaccines will be coming, but they won't work 100%. They'll work 50, 60% perhaps at the beginning. So, but each slice of cheese will eventually block the virus because it'll run up against another slice in our defense, and we'll dampen the virus. But that will take a couple years to put those in place. And as we don't do any of those preventive measures, again, then the virus can get all the way through to where we are at the end of the slices of Swiss cheese. I just thought that analogy was interesting to visually. We need all the slices in rows to have the best protection, and will dampen the virus from the risk from getting to us as a family, as a community, as an individual, but we won't get rid of it. I think personally, you said, how does it affect us or our work? As Ryan said at the beginning, Madison, is that I work a lot in Africa, and this virus is affecting all countries, and we've pivoted there to help the government of Botswana, where we're partnered to really respond to the virus. But also, this is obviously in our own backyard, and with the city of New Brunswick and the city of Newark, we've been working closely. And it's been just striking from, we work with a group called New Brunswick Tomorrow, and it's a consortium of bi-monthly, everyone that works in the community, medical and otherwise, in New Brunswick. And so to speak, all the groups that work in food banks, job support, housing for homeless, have all been stretched beyond the limits months ago. So even beyond the loss of jobs, and then the loss of housing, the inability to pay for prescription drugs, but really the inability to pay for a significant proportion in New Brunswick of the population for basics. People choosing between having to have a phone, which is needed, internet service, which is needed if you're going to school from home, or if you're just going to communicate, and be able to pay rent. People not being able to pay rent, and still coming up against eviction, even though that's against the governor's executive order. So the other things that's driven home to me is that drives home this individual dire circumstances is the number of people just in New Jersey. It's estimated by the Community Food Bank of New Jersey, a consortium of all the food banks, that over 1.2 million people are food insecure in New Jersey. And in New Brunswick or Middlesex County, that's almost 100,000 people that live week to week without enough food, or 35,000 children just in that city or surrounding area around New Brunswick, really going hungry at night. And the food banks, Elijah's Promise, McFoods, which is in multiple places around the state, but also in Middlesex County, both have seen triple or quadrupling of the numbers of clients, and they've had to also scale back what they can do, because they have to do social distancing and protect their own workers. And so it's really dire, I think, for a large percentage of our neighbors in Rutgers hometowns, our home counties in Essex and Middlesex and Camden. So I guess that's, I could go on, but medically speaking, you know, so much depends on your social circumstances, and we call it academically the social determinants of health. But basically, it's hard to think of getting solid medical or mental health services when you're hungry, you don't have a job, you may or may not have housing, and you really don't have the ability to get that job for the foreseeable future. So I guess I'm painting an individual picture that's dire for many of our fellow neighbors in New Jersey.
I actually had a question, not to, but to pose to Dr. Marlink. I am curious, sort of in Southern Africa, I do a little bit of work in South Africa, and there's been this, you know, I don't know what they call it, right? Sort of the you know, Africa dilemma, that, you know, or surprise really, that the number of cases has not really been so devastating, and maybe that's because the population overall is younger. But you know, people have talked about that. I'm sort of curious what your perspective is on that.
Yeah, we certainly hope it'll stay that way. It hasn't stayed that way in some places like South Africa. And so it may just be a slower wave to be blunt. I mean, people don't travel to most places in Africa internationally like you'd go between places in China and the US and Europe. And so there may just be a slower introduction of the virus. Many of the African countries responded quickly and have not only shut down their borders, but really followed China's lead, as it were, and said, we've got to address this, and we have to have social isolation initially, and have people wear masks. And I think it's not that it's happening uniformly in all the 52 countries of Africa, but I think in general it has been gladly less than expected, and some of it may be that it's a younger population and other things like that, but we just don't know yet. I think we're really early living with this virus as a species. I mean, I'm reminded constantly where I've worked in AIDS since the beginning of the epidemic, and that we've seen that evolve between the host, which is us, and the virus, which is, you know, HIV, and we've seen it change over the years globally. And so we're just starting to evolve with this virus, unfortunately. So we don't know.
Yeah.
I have a related question. I spent some time looking at countries in Asia, particularly those that had experience with SARS. And this should have been a wake-up call to everyone. And for a while in the United States, it was. Lots of beautiful reports were created, and they're all archived, and essentially nothing was done. But that's not true. And then the countries that experienced SARS, I mean, they seriously built an infrastructure, and they could put it in place like that. The examples are legion, Taiwan, Singapore.
South Korea.
Yeah, South Korea. And it's possible that can't translate into so-called liberal society. And you know, I'm wondering the extent to which countries that had experience with Ebola were more prepared than we were.
In an African setting, that may be the case of Ebola is, you know, obviously has much more deadly and much more higher lethality and rate, but that was a wake-up call to really not stretched or non-existent health systems in Liberia, Sierra Leone, and other African countries that really said, okay, we're going to deal with this seriously because we have to. And maybe that's a silver lining of the Ebola, generally contained Ebola epidemics of late, although it's still not contained in the Eastern Congo, but yeah.
Thank you. Thank you. Someone else want to jump in? You all have different expertise in different areas, and so it would be very good to hear from everybody and then generate discussion before we go on to the next topic.
I have one thing. I don't mean to be talking too much, but I've been struck by we're at the tip of the iceberg, which is what we see, which is terrible. The number of deaths, the sadness that causes, and the immediate morbidity of the infections of people that are hospitalized or still very sick. But the other part of the iceberg is, which we're just starting to appreciate, is, and there's Facebook self-help groups about this, the long haulers, they call themselves, meaning the large percentage of people that have long-term sequelae, long-term problems, central nervous system problems, cardiac or microvascular problems, lung problems of still having low oxygen after you've walked a small distance, kidney damage. So the acute damages that are happening, and most people do survive the acute damages, but the systems that we realize it's not just a respiratory virus, it affects the other systems in the body. But then there's also those same systems may have, for a certain number of people, long-term outcomes where the morbidity stretches out for months. We really don't know yet that part of the iceberg that's under the water.
And I suppose we could talk about comparatively the countries that have fewer resources. So talking about vulnerable populations, vulnerable countries, and what's happening is what would be expected. I mean, what's going to happen in India is just chilling. The virus now is just whipping through Latin America.
I wanted to just I didn't want to talk necessarily. I just wanted to share this quote, which was David Rolfe is from SEIU. And I just was really struck by this particular quote, right? So what was distinctive about the American situation, right, that rendered us so vulnerable, right, to the devastation and the sort of not only coronavirus, but sort of the economic consequences. And I felt like this was, we already were in a very kind of fragile place, and it was because of our level of inequality. I mean, some of the I won't go through all this, but just some of the populations who are particularly hard hit, right? It's not necessarily because they are hard hit by the virus per se, but hard hit by the economic structures that we have, unfortunately, that underlie much of our social and economic system. And so I just took this from Brookings, but here's something from Urban, right, where they took a look at sort of industries that were high contact and high risk, and many of which were deemed essential, the employees of which were deemed essential workers. And they bolded where you see an overrepresentation of Black and Brown employees, basically. Right, so you can see that this is kind of the pre-existing condition that we were working under. And it's been interesting to me as someone Asian American to sort of look at how sometimes our failure to disaggregate the numbers can also obscure certain dynamics. So, you had actually a lot of, API employees basically as frontline health workers and other essential health workers. And if you sort of break it out, you can sort of see that subgroups might experience, quite disparate impact. And I also just want to point out one other kind of economic feature that we should just keep in mind, which is, sort of when you think about who's hardest hit under our current circumstances, right? You have to sort of think about what cushion and what liquidity people have to kind of bridge this sort of exogenous shock, right? And the just racial wealth gap is so extreme that, you basically have people who are positioned, white families are positioned to sort of be more resilient because of wealth, right? And so this is something that, right, a sort of, race neutral discourse is not going to capture in terms of sort of vulnerabilities. And these are also elements that really have nothing whatsoever to do with, right, genetics. And so that's just sort of something that I just wanted to sort of put out there to begin the conversation, and I'll stop sharing.
Someone want to speak to the inadequate or let me do that again, unequal distribution of healthcare resources in different communities and how that has contributed, if it has, to disparate impacts.
Yeah, so I was just going to say my context is that I provide civil legal services for individuals with complex health and social needs. So multiple pre-existing diagnoses before COVID even started. And we often see the racial disparities borne out in the health outcomes and life outcomes of all the patients that we work with. But I especially think, I love that quote that you shared, thank you. I was earlier in a conference actually where we had a doctor who gave a quote that basically said, race isn't the risk factor, but racism is the risk factor. We really need to name that and be really intentional about saying that. That it's not actually that there's a racial difference per se that is exposing people. It's the difference in treatment is what is exposing people to COVID. And in talking about the wealth inequality, I think that one of the things that my clients often face is just not having a car. And so not only are they vulnerable because they have multiple chronic health conditions, but also they don't have access to the type of private transportation that a lot of us do. And so they're taking the bus to get to their appointments. And because they have so many chronic health conditions, they have more appointments. And because they don't have internet, they can't do telehealth. And so it's just this compounding factor of just a variety of systems clashing and interacting in ways that really make them at particular risk for contracting COVID in the first place, but also receiving inadequate or not helpful care if they do contract it, and being at higher risk of long-term health consequences or death. So I definitely see that that is constantly bearing out in the lives of my clients for sure.
Thank you. And I would add, this is what I meant, it's all of society. I would add housing and density, right? So vulnerable populations tend to live more in multi-generational homes, more in places where there's, in rural areas or urban areas, greater density. And so that, of course, leads to greater exposure and greater spread. And what else can we talk about? We can talk about
well, there's also generational differences in composition. So the houses might not only be more people, but also a greater generational divide. And so that can put people at greater risk as well.
Yeah.
You have grandparents, great-grandparents living with you, that changes the game.
Yep. And then there are cultural factors. I mean, a lot of the super spreader events have occurred in cultures in which they just simply cannot live their lives without family get-togethers and the like. And that has contributed. And so, this is just so multifactorial. And last but not least, the lack of health insurance, right? So if I have this, but I don't know where they are right now. If you map together the hot spots and the states that have refused to adopt the Medicaid expansion, and for those of you who don't know what that means, it's part of the Affordable Care Act, in which Medicaid was supposed to be expanded to all people who didn't have access to any other form of health insurance, and particularly persons without children with incomes lower than 138% of federal poverty. That's very low. So and the last thing, the Supreme Court and National Federation of Independent Businesses, the first Supreme Court decision regarding the ACA, and we have one coming up and we're all praying, made the Medicaid expansion optional, whereas the act was designed that it was to be mandatory. And so that meant, we would have, to a large extent, much greater universal coverage than we have now. So, as one would expect, the areas in which people are not part of Medicaid, areas in which wealth is less concentrated, and even if people have insurance, they will not access because their cost sharing out-of-pocket costs are so high that they just don't exercise the rights of insurance except for use it for catastrophic purposes. And so, if you map all these things together, you see the tight correlation.
And I just want to amplify that those inequities are ultimately rooted in current and historical oppression. And when I've spoken about COVID-19 and the way I think about it is through the lens of critical theories like critical race theory, which is going to destroy the U.S. apparently and is wholly un-American, right? Because what it challenges us to do is to think about the systems that undergird oppression and these inequities. And so it ties the inequities to our history and to the present systems of oppression that face those communities that are now hardest hit by COVID-19. And I'll just give you a couple quick examples. So I work with LGBTQ youth of color and doing participatory research with community-based organizations in New York City and Newark and Atlanta. And for LGBTQ youth, even before the pandemic, they are 120% more likely to be homeless than other youth. And during a time when having a home is healthcare and having a home is disease prevention, we knew right at the outset that LGBTQ youth were going to be most affected. And although we don't have a lot of evidence right now, what we're seeing emerge is that COVID-19 is affecting LGBTQ communities to a greater extent, not just from the disease, but particularly the psychosocial effects. So for LGBTQ youth, right, if we're thinking about one of those psychosocial effects for youth having to stay home or potentially doing school from home, for many youth, that's very stressful. It's isolating. It's very difficult. For many LGBTQ youth, on top of that, what they're facing is that they're potentially in a household where they're not in a safe space, where they're facing stigma on a day-to-day basis because they're not accepted for their gender or sexual identity. And they're not connected to some of the life-saving programs for them that have been scientifically shown to reduce mental health problems, to reduce the risk of suicidality. And those include, community-based organizations that provide safe spaces. So in New York City, one of those is Hedrick Martin Institute, that is specifically geared towards providing programming for LGBTQ youth, kind of across the spectrum, including things like housing and mental health support. But also in-school programs are really important. Things like gender sexuality alliances, also known as gay-straight alliances, are really powerful and really protective for young people. And what we've seen in the context of New York City, kind of pulling back to structural oppression, is that with COVID-19, we're seeing huge financial impacts. And so New York City mayor and city council just passed, not just because it was a few months ago now, they passed a budget. And that budget has impacts. And what I've seen for our partners at HMI in New York City, the community-based organization, and the Department of Education, is that their budgets were slashed and they're struggling right now. All while the NYPD budget was moved around. It was moved around into the Department of Education, right? So money was put aside for police in schools. And at the same time, the LGBTQ office in the Department of Education got 3 of 4 employees cut. There's 1 employee in the LGBTQ office in the Department of Education right now. That 1 employee is tasked with overseeing all programs, bullying, reporting, all sorts of care and support for LGBTQ youth in the Department of Education. That same office in cities much smaller, like San Diego, has over quadruple the number of employees. And so during a moment when LGBTQ youth are really, we know that they're going to be hit hardest by COVID-19, we are making structural decisions to deprive them of the support that's going to help them get through in terms of having a house as healthcare, but also really critical mental health and psychosocial programs. So we really are, instead of, I think, confronting a history of oppression towards LGBTQ communities of color, we are recapitulating in this moment. We are making things worse. And what I really fear is that as budget decisions in the future continue, that we are going to see communities of color and queer communities again not supported, and left out.
Yes, thank you. And a number, both Dr. English and Dean Ho have touched on this. This is even built into the data we collect. And so all this just flies under the radar screen. One could say that these people are generally powerless in the political system, and you could say that, some participants in the political system really don't care about these people to begin with, right? But it's more structural than that, in that the data sets just don't have these sort of categories in them, and moreover, even if they are in there, the data are not collected. And an example, the category Hispanic, is a construct. It doesn't exist in the world, and yet that is our primary category used in order to try to determine many things about the Hispanic population. And so, as Dr. English said, the roots of this are so deep. So, you can think about housing, and we can go back to, Jim Crow in the supposed liberal areas in which the suburbs were closed all over the country, right, including the North, because of restrictive covenants that were enforceable until, Supreme Court, I forget what year they made the ruling. And so, this just kept everyone except for, white, wealthy people out of the suburbs and packed them into the cities. And then, the unintended consequences of building housing projects and then tearing them down without any replacement and so forth and so on. It's just so deep. So given that, let's talk about possible solutions, right? And I prearranged with panels that I would start, because obviously this is a huge question, right? And so since I specialize in financing in particular, other nations which are doing a much better job. So let's limit it to other wealthy nations which are doing much better job than the United States, all have universal healthcare systems, right? And so until we have that, we're going to continue to have lots and lots of cracks and people falling in those cracks. And one thing that the pandemic has done, it has blown open any tiny crack in our society or our financing system, our delivery system, just blown it open to gigantic crevices, and at least made it visible. But you know, I got to tell you, at some point this will just go away. It'll drop out of political discourse, as always happens. But without universal health insurance, and without meaningful out-of-pocket limits, not like the huge ones created by the ACA, we're just going nowhere. And it's also a backbone for the delivery of services and particularly the delivery of community services. And then I know there are privacy concerns, but it also can be of great use in contact tracing, and as well as supporting people when they are in quarantine, which, you know, it is happening in the United States. And this is the wonderful thing about the pandemic, that the silver lining, the NGOs that have sprung out of nowhere and the existing ones, that what they have been doing is miraculous. But ultimately, this needs to be a function of government, and the idea of providing support, using, say, work share so people aren't laid off, as is happening in Western Europe, right? I mean, right now, guess what? That flies under, what name it flies under? Socialism. So good luck. Okay. Someone else.
Well,
go ahead.
I was gonna maybe, so I know we talked a little bit about, I'm torn because I really want to engage on the health financing question, but I also just want to say, right, that I'm obsessed with this now. So you guys are going to have to suffer from my little rage rant here. This could have been a moment of reset, right? And Dr. English is sort of saying, why are we not having or suggesting that maybe this is a moment where we should sort of take a serious look and have a serious reckoning, and do a hard reset, right? To try to reverse or ameliorate some of these really sort of unhealthy sort of fissures in our society. And I just wanted to sort of show you that that's not what we've done at all, right? So we have shoveled out $2.4 trillion in coronavirus relief. Okay, and I like this chart. This is from NPR, but it's very hard to read. Basically what they did was they took all the bills that we've passed and they kind of stacked them on top of each other. The earlier bills are in darker green, right? So the stacks of greenbacks that we've sort of shoveled out the door. And look at,
you know, we don't see it yet.
Oh, so sorry. Let me share. Maybe I've, here we go. How's that? Can you see it? Can you see it now?
We can see it.
Yeah. Yes, thank you.
Okay, so the rightmost bars, okay, the rightmost stacks, these are obviously where the bulk of the money is going. So take a look at the last four columns, right? What is in that last four columns? The second to last column is to individuals. So this is the amount that goes to the real economy, right? And then the rest of the last four stacks are to all businesses, big corporations, and small businesses, right? So in law, we sometimes call these legal persons, not natural persons, right? Unnatural persons. So it's looking a little bit like, right? It's not even one for you, one for me, right? It's somewhere on the order of 2 to 3 for you, right? 1 for me. And I just want to, so to me, right, look at, we have what, 1 out of every 10 households who say that they have not had enough to eat in the past 7 days, right? And what have we spent additionally on SNAP? 21 billion is what CBO estimates for the year, okay? Child nutrition, this is for schools to allow for free school lunch, right? To be actually given to children who are remote learning, right? Food banks, only 450 million. Okay, so what are our big ticket items? The $1,200 checks, what was a big ticket item? Unemployment insurance, which has since lapsed, right? Expanded unemployment insurance was 269 million. But check out what we have given to big companies. So 700 to 800 billion, this is the second bullet, in no fee loans and loan guarantees for small businesses. And this was supposed to be for them to keep their employees on payroll, right? Well, with the timing of the Trump guidelines, they actually were unable, they didn't have to do that. Nobody checked. Banks were the ones who were delivering this, and banks could choose their own clients, right? People who had a relationship with the bank to begin with. And so it turns out that Black businesses were denied at a rate something like 4 times the rate that white-owned businesses were denied, right? The first bullet point, the Economic Stability Fund, 454 billion, so half a trillion basically. And this wasn't even the money that companies could pocket. That was just seed capital, right? To reinsure the Fed should they experience losses from having bought, right, the bad debt from these companies' bonds and credit. Okay, and that's this could have been leveraged up to $4 trillion, right? So the amount of money, right, that is in some sense being expropriated, right, from our communities and redistributed upward, right, to these what we call legal artificial persons, not the real economy, right, the financial economy. And this is why, right, you have 30,000 people or 30 million people out of work, and people's stock market portfolios are soaring. And I just want to say one last thing, this tax relief, $221 billion, 135 billion of that was for the tax breaks that allow the redistribution of losses, right, to other years, and allowed Trump to pay no more than $75 in taxes in any given year, and sometimes 0 in taxes, right? 135 billion for that provision alone, 21 billion for food stamps.
Yeah, and I'm sorry, Christine.
No, I was just going to say, so this is a picture of not what we should do. This is a picture of exactly what not to do in this moment.
Yeah, and the same thing is occurring in the distribution of funds to providers. Right?
Yes.
So, the money is not going to the safety net hospitals. It is not going to locations in which there's inadequate capacity.
That's right.
Decision was made to base the distribution on Medicare revenues, and guess which kind of institutions have the largest Medicare revenues. And, I've heard that this was unintentional or whatever. I don't believe it for a second, right? Because they have staff and they have the data sets and they can design a system and just like this, figure out where it's going. So for example, when the money for the prospective payment system, the hospitals is distributed, and various proposals for rural hospitals to get it and so forth, legislative legislative text and regulatory text was channeled by congressional staff, right, through the databases, and a game was played, pick the hospital, right? So I don't believe for a second that this was unintentional. And so, I think your point, Christina, Dean Ho, about this not being a reset is just so well documented. And I've never been a fan of American exceptionalism, right? And for those of you who don't know the term, it's the idea that America cut itself apart from the old world and all the problems in the old world, and we're the light unto the nations. For many reasons, I think that narrative has been incredibly wrong and destructive. But leaving that aside, what's happening right now is American exceptionalism. I know this is also cheery. I often say to my students, right, I need to go into something more cheerful, like rape, murder, and mayhem. I'm sorry, Dr. Marley.
Sophisticated corruption is what I would call it. You know, I work in Africa, and everybody said, "Oh, those corrupt countries." I said, "No, that's straightforward corruption. We're just very sophisticated and well versed, and it's institutionalized corruption." But I wanted to get in what we do have to do about it. We really have to demand something. We can't be academic about this. We have to demand what we all know is happening. And we have to, those of us in public health have always been like, oh, we really should do this. And we complain about the problems, and we study them. But this is not going to change if we don't, to a person, demand change. And that's why I also get irked. I use the term I said before, social determinants. It sounds very, it sounds like it's something in a laboratory, or it's academic terms. We have to get down to the demanding that it's called racism, not race. It's caused, this is not a predetermined condition, is not race. We have to demand this. No one should say that. We have to demand that that's not presented anywhere. But also we have to demand it from ourselves. And that means, yes, we're going to have a society where the companies and the people with money give up money, and we distribute the wealth. It's the only way we're going to do it. Talk about universal health care. That's how it's going to be more expensive. Universal public health care, it's going to be more expensive, but we have to demand it.
As well as breaking down the barriers between healthcare delivery and public health, right? And so, I meant
both have to go together. Yeah.
I go past the arguments regarding, aggregating them. In fact, public health should be dominated, and delivery systems should be designed to further public health. And that means not investing in the providers, but investing in the public and restructuring the delivery system so that it is community-based and it is participatory. Dr. English, I was glad to hear you're doing action research design, and that's what I mean by participatory. And so this is soup to nuts. It just has to be unwound, soup to nuts. And just when November 2016 happened, I talked to colleagues in different disciplines all around the country, and this went on in November and December, and I was asking people, economists, political scientists, other law professors, are you able to work? And there was a period in which almost the universal answer was no, because everyone was so demoralized. But then what happened? People joined the battle, right? And were activated in a number of different ways, and have fought and fought and fought and fought. And so regardless of the outcome of this election, the fight has to go on. I think I'm sorry, Christina?
Oh, sorry. One last thing that I was just going to I was curious what other people thought about. Sabrina Corlett, who is at Georgetown Center on Health Insurance Research, right? I felt like she wrote something so interesting early on. This relates to your point, Professor Frankford, about sort of the relationship between public health and health delivery. And she said that early on, she was basically calling for, no copay testing, right? But then she realized that is not the way to go, because a lot of the testing that we need to have happen is not really diagnostic testing, right? It's testing that might be related to whether or not you can go back to work, or whether the kids need to be routinely tested to be able to be identified, if they're going to school in person. And she said we actually really need just free testing from some kind of pot of money that's run by the public health department, because otherwise otherwise you have, well, is there some clinical reason why you need to go see the doctor, and they, measure your clinical criteria and see if you qualify for the test and reimburse you later. But that's not really what we need right now.
Yeah,
So
and even the CARES Act, which supposedly, according to the president, was going to make testing widely available, universally available, without cost. Even the CARES Act has been horribly ineffective. Insurers have taken the position flat out that they will not cover, pay for testing that is something other than diagnostic and backed up by a prescription. And so that so narrows the field. So even a tiny, narrow sliver of legal reform has largely failed. Why don't we at this point open, because we are running over, why don't we open things up to the audience? So Ryan, you're gonna moderate this?
Yeah, so I can moderate. If anybody wants to use the raise hand function, I can't see it on my screen. It might be because I am one of the co-hosts, but if anybody has a question from the audience, you could feel free to raise your hand. And I also don't want to stop this discussion we're having now. If there's nobody raising their hands, feel free to jump in and continue while we wait.
Or feel free to put a question in the chat if you don't feel like unmuting.
I was going to say, I'm going to throw a link in the chat to the Trade-Offs podcast. It's a really good podcast, and you can actually listen to one of our patients talk about his experience trying to really kind of weigh his desire to stay healthy and his access to medical appointments and just what that means for him during COVID. And I think that it's important that when we're talking about rebuilding and breaking down systems, that we have the communities be actually integral into that part. The ones that are being served need to be part of that, not just in name, but also have actual power and decision making involved in restructuring health systems and delivery models, everything. Not just like, yes, we've talked to someone with lived experience, but have them integrated within the whole system. So I'm going to throw it in the chat just for your personal enjoyment.
That would be great. Thank you. And Professor Ho, do you have a link, or would you be able to share the slideshows that you were showing us earlier, whether we could send that out in an email after this?
Sure.
That would be great.
I don't have
There's
it
a lot
in
of
link,
good.
but I will email it to you, Ryan. How about that? And then
Sounds great. Yeah, and I'll share that with everybody who's here and anybody who gets the Health Law Society emails, and I could send it to Madison. She could send it out to the OUTLaws email list as well.
Great.
I guess a question that I have off the top of my head is towards the end of this discussion, we talked about how we need a real restructuring in the healthcare system. And a lot of the times you hear that from professionals talking outside of COVID epidemic. What steps does that take? What form do we move towards to get to a certain goal where we would be in a better position to deal with pandemics like this, or one in the next couple decades? What are like the tangible goals that we could set and move towards as a society, as future attorneys, as professors?
Well, let me start with that. The model, right, has been that the people in the hospitals just sit and wait for people to come in. And at this point, even the major systems and the major insurers have recognized that that's inadequate, that the hospital has to go out. Now, this is just a trend which has been happening already. Say United Healthcare, which now owns almost everything, right? And other major players, buying up and creating capacity in the community. But, right, this is all individualistic. This is for profit. This is to create revenue for them, right? And so, where are they going to create the capacity? In a competitive system, guess where? I hate to sound like the voice of doom, really. Sorry. No hands raised, Ryan?
Not yet at this point.
Make a quick plug on how to move forward. I've in public health, I've recently been heartened by a very, I think, serious discussion about reparations as public health priorities. And the New England Journal of Medicine and two leading researchers, Sandro Galea, who's the dean of Boston University School of Public Health, and Mary Bassett, who's just a leading figure, has been in both academia and head of departments of health. I think both make a very strong point for to Dr. Marlink's point that we need to demand that we are taking not a colorblind policy approach, because what we have inherited is a system of inequality that is rooted in policies that were not colorblind, right? That were color-based policies. Slavery was color-based policy. The Jim Crow South was a color-based policy. The restrictive covenants and redlining was color-based. And so the idea that we are going to get out of this with a colorblind approach, not being a policy expert myself, but that seems absolutely absurd to me. And so I'll drop in the chat a link to that article. But for me, I think an example of a color and SES conscious policy that in this moment in COVID-19 is the idea that we need to be prioritizing our resources in the communities that are hardest hit. And we have not seen that, whether it's COVID-19 outreach. I'm in the Northwest Bronx right now, and the Department of Health here does not have a strong root in the Dominican community. We are a majority Dominican community, and there are not people who speak Spanish. There are not people who speak Dominican Spanish, and it's a systemic failure. And I'm really scared for this community, because I really think that we're going to be hard hit in this second wave. And all the while, what we're seeing with economic institutions, two major banks near me have just closed. So people who rely on in-person banking don't have access to that. And so what we are seeing is that the lack of opportunity, the lack of care is not colorblind. It's not socioeconomically blind. It's hardest hitting for Black and brown low-income communities. And so our policies can't be colorblind. They can't be blind to those, to the conditions that are uniquely facing Black and brown and low-income communities.
I would just say that given that the judicial takeover is now complete, unless this administration continues and the Senate continues as it is, then it's not complete. But given that it is complete, I think there's little possibility that of law being anything other than colorblind, which, as you know, is just a continuation of historical social conditions. And so that's why I think somehow this has to rise out of civil society in the United States. I'm not exactly sure how to accomplish that, but I think we're about to enter a period like the beginning of the New Deal, in which let's hope progressive legislation and regulations are passed and written, but sorry, someone's at my door. I'm about to have no barking. Sorry. are going to be written and run into a brick wall. He's guarding the castle, brick wall of the courts, brick wall of the courts.
One plug I will make for state level policies is that you know, some of the policies that hit hardest for Black and brown LGBTQ communities are state level policies, things like HIV criminalization laws, you know, stop and frisk laws in New York City. We have walking while trans laws that are you know, almost exclusively enforced on Black and brown LGBTQ communities. And so, you know, to the degree that we can fight that fight on state and local levels, you know, that's a fight worth fighting for. So
Yeah. Though I would note that this court is now showing that it's quite willing to intervene into state law when it suits political purposes.
Don't we need more Supreme Court justices?
That's
in
outside
the Biden administration. Got to double the number.
it's historical precedent, right?
Okay, let's leave that one aside.
I was also going to say, I think there's a lot of movement in the state level as well for fines and fees work. We know that fines and fees are disproportionately impact people of color, people of low socioeconomic status. And so that's definitely a state issue. And that has to do with the way that our municipal court system is set up and just the way that our municipalities are funded. And during COVID, I'm especially concerned with the impact on people of color, especially, but also poor people generally. Because we know that back with the 2008 recession, that municipalities then turned towards their fines and fees regimes to try to help make up some of that revenue loss. And we know that New Jersey is facing great economic loss through COVID-19. So there's definitely some advocacy to be done in that area for sure.
Yeah, and I would say more generally, I mean, we somehow have to diffuse power in this country. I know for some reason I started out as a Foucauldian early in my career, read everything in English and taught it and write about it. But I think at this point in time, you know, the notion that power is local is where it's at. Other comments? No questions?
Well, don't we all have to decide individually and as groups of who we work with or live with or interact with? We all have to decide, what are we going to do about it? I mean, if we're not going to be activists about this, then we never are. This is what we have to decide before, especially on November 4th.
Well, and even after November 4th, I mean, frankly, I'm thinking, you know, depending on what happens, jumping the academic ship and, you know, actually getting out there.
I would just say that from a public health professional, because, you know, public health professionals, I feel like have largely tried to stay out of, you know, advocacy. And so, you know, and I don't think that's as much the case for, you know, legal studies and lawyers. But I'm heartened by that. I'm heartened by the fact that public health professionals are getting into advocacy and saying it's not enough to prove science. We need to see this science enacted. So I'll say that.
And there is an opening for that. I mean, you know, what has largely prevented that over time has been that you know, the division between public health and medical care grew out of, you know, it didn't grow naturally out of a division of labor, but instead political and economic power. And so anytime public health threatened medicine, you know, they just got stomped, right? But at this point, to some degree, medicine has been weakened in the political process. And so, you know, possibly there's an alliance with, you know, systems of financing. I don't know, sleep with the devil.
Well, ironically, they say that separating out the public health from medical schools and from the medicine actually served to make it have less power and be sort of over there rather than where the money was and where the decisions are made. So there used to be talk, and maybe there should be revived of joining everything together again. But the changes that are needed are much more basic than that. Much more basic than that.
Do you want to elaborate that thought?
Well, just again, I think we all have to figure out what we're. It's easy to talk, but you know, when people say, "Well, I have mine," and don't get into my pie. I'm willing to talk about it and help a little bit, but don't bother my pie. Whether you're a big corporation, whether you're whatever you are, don't. If the status quo is fine for you, don't change the status quo. Psychologically, that's the biggest hurdle we all have to figure out for ourselves and for our immediate pods.
Yep.
We're all in pods now.
Well, Ryan, what do you think?
Well, it looks like the questions are wrapped up with that one. But if there's any more questions, feel free to email them out to the HLS email, or I'm sure most of you have my email who are still on this participants list. But thank you, everybody. I know we can't clap, but I could do this little reaction emote in the corner of my screen to clap, because this was a great discussion. I think I speak for everybody when I said I learned a heck of a lot from all of you, and I'm glad you were all able to come together to talk about this. So thank you.
Thank you.
Thank you.
Thank you
Thanks,
guys for
Ryan, for all
organizing.
your work on this. Thanks.
Of course. And if anybody wants to stay on and chat afterwards, I'll stay on so the Zoom stays alive. But you're all free to go. Thank you so much for coming out, everybody.
Thank you for organizing.
Everyone,
Thanks.
have a good evening.
Let's
Bye, everyone.
let's go join the Biden administration.
That's what I had in mind.